Hello, and a really warm welcome to this Health Foundation webinar entitled What Will Make the 10-Year Plan a Success? My name is Ruth Albee, and I'm an Assistant Director in the Policy team, and I'll be chairing today's event for the next hour and a bit. You'll be hearing from four excellent colleagues of mine and experts in their field: Phoebe Dunn, Tim Horton, Penny Pereira, and Gwen Nightingale. I will introduce them properly in a little while. But first, I thought I would kick off with a little bit of context for this webinar, which many of you will know, but it's worth rehearsing. Pressures on the NHS are intense. There are still over 7.4 million cases still waiting for elective care treatment. The 18-week target to treat 92% of people within 18 weeks hasn't been met since 2016. The emergency care services in hospitals are still under massive pressure. In February, nearly 47,000 people waited over 12 hours on a trolley in A&E before they were admitted. In primary care, there's been an increase in people, steady increase, reporting difficulties getting through to the GP on the phone, and a steady decrease in those saying that they can see their preferred GP. Meanwhile, there are record lows in public satisfaction, according to the British Social Attitude Survey, which has been running since 1983, with a particular acceleration in this since 2019. There's a mix of causes for all of this. There's a decade of underinvestment. There's COVID itself. There's been weak capital spending on IT and buildings with a huge maintenance backlog. There's been restructuring of organisations, and there's been neglect of social care, with many people still without the care that they need, pressure on carers, but also local authority budgets. New government came in last year, declared the NHS is broken. It had to reform or die. It commissioned Lord Aradazi to do a review last summer, published September, and it didn't pull its punches on what was wrong with services right the way through from mental health to community care. Last October, the government launched its 10-year plan, designed to show how reform was going to happen. It outlined three key shifts it wanted to see. It wants care shifted from hospital to community. It wants a shift from analog to digital. And it wants a shift from sickness to prevention. There was a huge consultation exercise launched at the same time with patients and staff, and a plan was promised in spring. We now think June. Since it was launched, there have been some developments, of course. In December, the Prime Minister launched a high-profile political target to achieve 18 weeks in 5 years. So a lot of focus there on the acute sector. It's not clear what the government's approach will be to reform. On the one hand, there have been threats of league tables and sackings, but at the same time, there's been language about a war on red tape to liberate GPs. Last autumn, there was a welcome injection of funding for the NHS in the autumn budget, 22 billion over 2 years. But at the same time, in March, NHS England was declared to be abolished. ICBs had to reduce their numbers, and we hear about financial pressure across the NHS. And this is all happening in a much bigger environment of huge global political and economic uncertainty. The next phase of the spending review, the date is clear, June the 11th, is simply not clear whether there's going to be much headroom for much growth in public spending. So that's the backdrop for this webinar, and it'll be a chance to hear a bit about what we think the priorities are as an independent foundation based on our research analysis, which includes research with the public, polling and deliberative work, but also insights from our years of practical experience working on improvement with teams across the NHS and social care. What's going to happen over the next hour and a bit is that we're going to hear from our speakers first, and then we'll take some questions from you. Now, the questions need to come into the Q&A box. Don't send them on the chat, you won't be able to do it. So put your questions in the Q&A box, and you can upvote them as well, and we'll do our very best to get as many questions as we can. Just to note, this webinar is being recorded. The recording will be on the website within 24 hours, and a subtitled version will follow shortly. But before we get going properly, we wanted to take the temperature really a bit from you. So we have a polling question for you, which I hope will pop up in a second. And the question is, how hopeful are you about the 10-year plan? So let's just see what you all think. Now, I can't see at the moment what the results are. Maybe somebody can fill me in on how we're doing. Okay, this is interesting. We've got most people in the middle. So 1, not very hopeful. 5. So we've got most people clustered in the middle. You're hedging your bets. Okay, really helpful. Thank you for that. We may come back with some other questions during the session. So let's get going really and hear from our panel. Let me introduce them first. We've got Phoebe Dunn, who's a senior fellow in our policy team, who works on NHS reform and integrated care. You'll be hearing from Tim Horton, assistant director in our insight and analysis team, who works on tech, AI, and innovation. We'll be hearing from Penny Pereira, who's the managing director of our Q community, which is a UK-wide membership community which works on accelerating improvement of care in lots of different settings. And Gwen Nightingale, assistant director of our Healthy Lives team, who works on the wider determinants of health, the building blocks of health, and inequalities. So first up, let me invite Phoebe. And our question that all the panelists are going to reflect on to begin with from their various perspectives are, what do you think the top priorities are that are critical to the success of the 10-year plan? Over to you, Phoebe.
Thanks, Reece. And hello, everyone. So my starting point for this, I guess, is to think that, well, the NHS is no stranger to long-term plans. In the last 25 years, we've seen at least 3 big ones. So what can we learn from kind of looking back at some of those, thinking about the current context, and thinking about what the plan needs to do overall, and in terms particularly of making progress on this shift from hospital to community, which again, isn't kind of a new ambition. So first, I think government needs to provide hope that things will get better. It's been a strong emphasis on the depth of the problems facing the NHS as this government has come into power. The story now needs to turn to the strengths of the NHS and set a clear direction for change, tapping into that kind of enthusiasm, creativity, intrinsic motivation of staff to improve care. This also means articulating that vision for the future of primary and community services and some greater clarity around plans to develop this neighbourhood health service. So that's kind of first thing. Secondly, I think the plan needs to set really clear priorities. The tendency for past plans, again, is to kind of say that everything is going to improve everywhere all at once. But if everything's a priority, then nothing is. And the NHS needs a really clear sense of what's important. There's been some progress, I think, on this, but more to do and more clarity to add. Improving primary care should be really high on the list and is the public's top priority. The current model is well designed to offer high quality care, but we know people are struggling to get GP appointments and continuity of care is declining, which is, we know is really important, particularly for people with long-term conditions. And these problems are often worse in more deprived areas of the country. So any changes should really need to build on the model we've got and think about how to support primary care to improve. Now, as I said, the previous ambitions to shift more care from hospital to community haven't happened. And looking back, the system's kind of become more hospital-centric over time. So the 10-year plan needs to set out a clear mechanism for achieving those ambitions to invest a growing share of the NHS budget in primary and community care. And then it needs to revitalise general practice as the bedrock of the NHS, with a really clear focus on ensuring practices in the most deprived areas of the country have the resources they need to tackle those higher levels of need. So some priorities here around recruiting and retaining more GPs, better integrating those growing number of professionals into primary care, improving some of those systems and processes that those operational failures that we know are holding back GPs, and thinking about ensuring financial incentives really promote high quality care. And then my third point, again, looking back, is that I think recent NHS plans have been weak on how care will actually improve, how things will change. So the plan needs to really think about how the system works, how these policy changes work in tandem to kind of guide things in the desired direction. So thinking about things like how resources are allocated, how providers are paid for the care they provide, how providers are regulated, and more. Again, thinking about this kind of hospital to community shift, loads of previous plans have said it. It's a really good ambition, but they don't say how it's going to actually happen. Other priorities dominate and it doesn't happen. You end up with this kind of big gap between rhetoric and reality. So what's going to be, different this time? And some policy levers are really ripe for reform here. We know national NHS performance targets steer what gets done, but those are heavily skewed toward hospitals. The NHS payment system is a really complex mess of kind of conflicting incentives. Quality regulation is undergoing a rethink. And of course, policymakers within all of this need to really strengthen the NHS's capacity to improve. I'm sure Penny will kind of come back to that in her comments. So just two broader, reflections to finish. One is that looking back at past plans, the context is really important, and there's no escaping the fact that investment is often a major driver of improvement. This government has been, really heavily emphasised the importance of policy change, reform, over investment. It's hard to disentangle the kind of effects of overlapping reform approaches like targets and money. There was a long-term plan produced under the Blair government, but there was also nearly 7% growth in NHS spending year on year. So the ideas were important, but so were the resources. They paid for capacity, equipment, staff, and right now resources are very constrained. So the context feels very different, and really need to view the kind of spending review and the 10-year plan together here to see what can be delivered. Capital investment obviously really essential this time round. And then my final kind of standing back point is just that the plan, this shift, the NHS can't really deliver in isolation. Some of the key elements to this, making the shift happen, have been excluded from the scope of the plan. So social care and public health in particular, thinking about this shift. So this is really only going to happen when the wider health, social care, public health system is properly and sustainably resourced, and in the case of social care, reformed. So I will stop there and hand back. Thank you.
Phoebe, lots there we can pick up on a bit later, but for now let's move on and hear from you, Tim, about what you think the priorities are for success.
Thanks, Ruth. And I'd like to think a bit about the government's ambitions to shift from analogue to digital. Our work at the Health Foundation on innovation over the last few years has more and more found ourselves dealing with technological innovation, and we've got plans to be doing even more of that in the years ahead. And obviously health tech used well offers huge opportunities for improving care, improving experience, and making care more efficient as well. But just to start with a really obvious point, the benefits of technology don't just come from having it, but from implementing it and using it effectively. When we support teams at the Health Foundation with technology, we see some of the work involved in that. Often you need to redesign your ways of working around the technology. Staff might need training. They might need to learn from each other what works and doesn't work. So one of the things we're wanting to see is health policy evolve from just a focus on technology procurement to much more of a focus on technology implementation and optimization to actually help the NHS get the benefits from it. Electronic patient records would be a really good example. The NHS has spent loads of money, and we're now at a point where nearly all NHS trusts have an electronic patient record system. But actually very few of them are using them to their full potential. So in a way, we're now at the starting line of a long journey for the NHS to try to reap the benefits of this investment. If we look at the US, which, although a very different health system, is about 10 years ahead of us on the use of electronic patient records, what we saw is that was quite a long journey. In the US, there are incentives attached to a plan really helping to get providers to get different kinds of benefits out of electronic patient records. And perhaps in a similar way, we'd like to see the government grip this and put in place a plan now to start realising the benefits on electronic patient records. That's just one example. The broader message, though, is that when it comes to technology, really you need to fund the change, not just the technology. That's not trivial. We produced some work last week looking at some of the costs that will be involved in digitisation. But critically, an important chunk of those were not about acquiring technology, but precisely about implementing it and using it well. Now, I guess an implication of what I'm saying is that it can take time to realise the benefits of technology, sometimes a number of years. And that's got really important implication. The NHS is really hoping technology can help it become more productive and deliver savings. And it doesn't want to wait years and years for that. It wants to achieve them right now over the next few years. Well, if it can take a while to realise the benefits of new technology, I guess the implication of what I'm saying is that in the near term, productivity gains aren't going to come from new technology. They're going to come from better use of existing technology. And whilst that's less exciting from a political point of view, we'd really like to see a focus in the plan on getting better use of technologies already in the system. Stuff that we were getting excited about a few years ago, like virtual wards, electronic patient records, as I've said, software for image analysis, video consultations, all of these things. The tech's now in the system, and actually there's the opportunity to start realising the benefits over the next few years. So we'd like to see more of a focus on that. Everyone obsesses about new technology because it's more exciting, but we're going to have a focus on existing technology too. It would be remiss of me if I'm talking about tech, not also just to mention AI. There's obviously lots of excitement about the potential of AI. To date, from the government, really, we've seen quite a cross-sectoral focus on AI from the Department for Science, Innovation and Technology. Things like the AI strategy and roadmap, the recent AI opportunities plan. These are dealing with very high-level issues of regulation and promoting innovation. But really, we're going to need a specific focus on some of the opportunities and challenges AI offers in healthcare if we're going to get the gains out of this. What we hear from stakeholders is that there's a range of important work on AI going on across the system, but progress is being hampered by a lack of overarching strategy, a lack of coordination and collaboration between national bodies. So we're arguing that the government needs to put more of a strategy in place, for example, on areas like regulation, workforce skills, infrastructure, and so on and so forth. We've argued that it's really important that an AI strategy is under the guiding principle of responsibility. By responsible AI, I mean not just that it's legal and ethical, but it promotes the greater social good. We need to be much more ambitious than just avoiding harms. We really want to be harnessing AI to be improving society and the environment. And as well as helping to improve collaboration, tackle gaps, a strategy on AI could also help prioritise some scarce public resources towards some particularly promising uses of it. At the moment at the Health Foundation, we're doing a fair bit of work on ambient voice technology. This is technology which can record consultations, transcribe them, turn them into clinical notes. If it works, it could really help clinicians focus on patients rather than being sat at the computer typing. So we're really interested to see how that goes. But identifying some promising use cases will be really important for a strategy too. Very final point I wanted to make is really just stepping back and looking at the broader innovation ecosystem as a whole. Over the last few years at the Health Foundation, we've done a range of work looking at what we call the spread challenge, the difficulty of replicating successful innovations at scale across the NHS. Contrary to the common narrative, the NHS is actually really good at innovation. What it's bad at is replicating that at scale across the system. And partly there's been a historic underestimation, not just in the UK, in countries all around the world, at the challenges of adopting complex innovations in the public sector. It can take a lot of work to do that. Teams can need support to do that. But when we look at funding for innovation, it's very heavily still tilted towards funding early stage innovation and pilots. We think that end of the pipeline is relatively overfunded, and support for evaluation, testing and adoption is relatively underfunded. So we'd like to see a bit more of a rebalancing of funding towards those later stages. That could be implementation support within individual programs. It could be broader capability building. But we'd like to see some rebalancing in order that the NHS can really see some of these pioneering innovations, not just in one or two leading organisations, but across the country.
Thanks, Tim. Lots to digest there. Really interesting work. And we'll come back to some of that, particularly the work that you've been doing with patients in the public as well, I think. So let's hear next from Penny Pereira, from where you're coming from, about what you think the priorities are.
Thank you. So I'm going to focus on implementation. So as Phoebe started us off, there have been plenty of reform strategies, but kind of few have fully lived up to expectations. Crafting and agreeing the words is hard, but it's nothing compared to putting them into practice. So I think there are 3 linked priorities for the 10-year plan to be a success when it comes to implementation. Firstly, I think the plan needs to acknowledge the scale of the transformation that it implies. That's going to help leaders, staff, patients be confident that the government understands the reality of what they're being asked to do. Those who work in the sector know that, each bullet point in the plan, every catchy commitment, may mean in practice redesigning dozens of interconnecting clinical and supporting processes in every place where that commitment is then introduced. Staff need to feel confident that changes that are going to impact their working lives and outcomes for their patients are going to be introduced thoughtfully in ways that maintain care quality and work for everyone. To build on Tim's comments, when I think about the shift to digital, for example, in the NHS, we've got a pretty poor record of ensuring proper time and support for the supporting change that's really critical to realising the benefits, keeping staff and patients with you. Our work in Q has shown that staff and patient trust and confidence can be a barrier to how far people use new technology. I'm reminded of work we did during COVID on the adoption of video remote consultations, an example of the existing technology that Tim mentioned. What we found is that for people to really back new service models, they need to see that there's a model for ongoing evidence building, factoring it into training, making sure all groups are catered for. When we're faced with such major pressures on the NHS, there's a real understandable push to be optimistic, to be high-paced about how quickly we're going to fix things. But, the reality is that many of the shifts that we're talking about are complex. They've proven resistance to change over many years. So what I'd like to see is that we recognise our energy is better put into designing solutions and implementing them to last, rather than pushing harder against staff resistance, which may often not be resistance to the change itself, but rather to how it's implemented. So that takes me on to my second point, which is that we need an approach to change that kind of stacks up. That doesn't need to be getting into the technicalities of change methodology, that we should be making the most of the evidence and the skills on that front. But what the plan does need to recognise as a minimum is that successful implementation is going to need action of different types to come together effectively. So we're going to need some clear, inspiring leadership, building of shared purpose. The publication of a plan is a great opportunity to set out the vision, but that's going to need to be interpreted and refreshed locally again and again over the next 10 years. There need to be ongoing mechanisms to build and sustain engagement and ownership. Particularly given the kind of complex, distributed nature of healthcare, we're only going to be able to implement the plan by equipping teams to design what each recommendation means for their service. That, for me, is one of the cases for the plan specifically promoting the use of improvement. So these are the approaches that I think give us the best chance of practical, inclusive ways to involve staff in making things better. So I guess the approach to implementation needs to be grounded in what will actually happen at the front line to convert these commitments to reality. But, it's not realistic. In fact, it risks alienating and irritating staff if that's not accompanied by action at system, regional and national level that's genuinely helpful. So we're going to need programmes to build momentum in priority areas. I work for the Modernisation Agency that used collaborative programmes as a key delivery mechanism for hitting emergency and elective targets back when the Labour government introduced the NHS plan in 2000. And we've got a lot of learning that we can apply to update our approach to some of the more complex changes that we're now seeking to make. So, we will need well-designed, well-resourced programmes, but we'll fail if we think about the 10-year plan just as a project or programme. Paul Corrigan, Department of Health and Social Care Advisor on the plan, talks about how every part of the NHS will need to change. We've discussed how that means transformation needs to become the kind of mainstream focus of organisations. All NHS organisations are going to need to be capable of prioritising, designing, implementing a portfolio of improvement and transformation activity alongside continuing to deliver services day to day. So that's going to demand something different from boards. At the moment, relatively few organisations have a management system capable of this level of sustained, reliable improvement year on year. We see lots of appetite from NHS England to make that, from NHS organisations to make that shift. But like the 10-year plan needs to just create the policy environment and incentives for organisations to change how they work in this way. It's that shift in the background to how organisations are focusing and using their time that will enable the big service shifts that naturally grab the headlines and matter to patients. So that brings me to my final point, which is, as Phoebe said, finding a credible approach to resourcing the plan, and specifically resourcing change, must be a priority if the plan is to succeed. Whatever the spending review settlement, we should expect resources will continue to be very tight, as Ruth said at the start. Others, such as my talented policy colleagues, will be better placed than me to get into the right solution in terms of those funding models. Wherever it lands, I think there are some principles from the world of improvement for using well the resources that we have. Whether you're working locally or nationally, I think we need to build a narrative, an approach to implementation that integrates productivity and quality objectives into our implementation of the plan, our transformation work. We just need to be upfront that the task is not just to design new service models, but to design services that provide better overall value for the public, and that we need to stop less effective service models rather than continuing them as a backup, which we just can't afford. There's a risk that our change effort gets diluted across too many things. We continue to waste a huge amount on initiatives that are underpowered and fall short. So that means we need to get better at prioritising, with interventions that are based on a robust diagnosis of what's important, and important for the system, not just for individual teams and organisations. We need to find resources for short-term changes, but they need to be selected to contribute to the long-term shifts, rather than allowing our resources to be too absorbed with quick fixes, as they often are at the moment. And, we really have to build on what currently exists. I know this is a new kind of 10-year plan, but we can't afford to waste existing talents and ideas. That means, as Tim says, using more effective approaches to scaling and spread, and making best use of our internal change capacity, which can then in turn unlock a full and sustained contribution from staff. So yeah, I guess I wanted to end on a positive. I've talked about the scale of transformation, the need for a sufficiently sophisticated implementation strategy. That can feel daunting given operational pressures and the limited resources available to us. Yet there is kind of plenty to build on within the NHS when it comes to implementation capacity, if we can utilise it well. Since Labour's NHS plan 25 years ago, thousands of people have been trained in effective service redesign, change and improvement methods. I see that in the work of Q, which now represents a diverse community of thousands, connections from the front line to those in leadership roles, a community that's actually globally unique in its scale. And we've got cost-effective ways now to build change capacity quickly, to reach well beyond improvement specialists, and where people can learn while making the change happen. So yes, the transformation ahead is huge, but there's people in every part of the NHS with experience that can help. Thanks.
Terrific. Thanks, Penny. Really good sense of optimism there, actually, which is nice to hear. So let me just pass over to Gwen now to reflect on some of the wider issues that may lie outside the purview of the 10-year plan, but are still probably really need some attention. Over to you, Gwen.
Thanks, Ruth, and hello everyone. I'm going to talk a little bit differently about some of the wider determinants of health. We've already, our health shaped by the world around us, things like where we live, good quality homes, stable jobs, social connections, living in neighbourhoods with green space and clean air. And these factors are what we call the building blocks of health. And we've already heard a bit today about the importance of healthcare. And this shouldn't be underestimated if the aim is to improve health and reduce the stark inequalities that exist across the UK. But, and it's a big but, while access to healthcare affects our health and well-being, the building blocks have a far stronger impact on the variation in health between different groups. And just to kind of pick out some of that variation, it's things like a 22-year average gap in healthy life expectancy between different local authority areas. and a 20 percentage point difference between ethnic groups in the proportion of people reporting good health. And this sort of difference doesn't have to be there. It isn't like that in other comparable countries who generally have a higher median life expectancy, and they also don't have the same extent of inequalities as observed in the UK. And it's as I say, it's important to remember that it doesn't have to be this way. And we know that because of what's happened in the past, and progress has been made in the UK before. And the health inequalities strategy published in the 2000s was successful. It led to a reduction in inequalities in life expectancy of just over a year for men and around 6 months for women. However, it took over a decade for that to happen, and longer still for the evidence of success to emerge. And as part of the health mission, government has set out ambitions to do more to reduce inequalities, committing to reducing differences in healthy life expectancy. But to deliver this, government needs to align action across its 5 missions to improve health for those facing the greatest inequalities. So thinking about the aims of the wider health mission and how that plays into work around the NHS 10-year plan, I think the first thing that's needed from the plan is to set a firm intention for government to drive coordinated activity on health beyond the NHS and signal its genuine commitment to a long-term, ambitious, preventative and cross-government approach. This approach, whether it's part of the 10-year plan or announced alongside it, needs to include the development of a cross-government strategy for reducing the health inequalities that exist. And this strategy would include things like realistic but ambitious targets to reduce health inequalities, and they'd be needed in the short and the long term, recognising the lag that can exist to see progress on some measures. Harnessing the potential of existing government ambition and commitments, but also looking to fill gaps in activity. A strategy should provide clarity on the role that all parts of the system need to play, and it should ensure that the system has the resources it needs to deliver, and where funding is constrained, review the allocation formula to direct funding to those areas and communities with the poorest health, as there's often a mismatch. A strategy must also create independent monitoring of progress, as accountability is key to driving impact. And finally, on the strategy, government should give consideration to making some of this legally binding. We know that making and seeing the progress that can be made in this area takes time, and having some activities bound in statutes might help to ensure an ongoing focus and drive the progress that's needed. And then the second point that I was going to mention in relation to the 10-year plan is that there is space for activity on NHS prevention activity as well. So including strengthening accountability for the delivery of NHS plans for preventing ill health and early detection and treatment of disease, taking immediate steps to restore the public health grant to previous levels. There's been a significant reduction over time. Develop a bolder approach on the leading risk factors for ill health. So we see that there's action on smoking through the tobacco and vapes bill, but wider action is also needed to address the other leading risk factors for ill health, including harmful alcohol use, poor diet and physical activity. So they're the two areas that I would like to see included in the NHS plan, a cross-government strategy, and then looking at what the NHS can do to support prevention, but recognising that when we're talking about health, the NHS is a player in that debate, but they aren't the only player, and it needs a much larger coordinated approach across government to drive progress.
Thanks, Gwen. Really good in a nutshell what our position is on this, and hopefully maybe we will see a wider step towards action. Who knows? I was just going to check in briefly with whoever wanted to ask this question before. We're getting questions coming through from the audience that would be great to have people's thoughts on. But really would just be to check in about if anyone had any reflections on what the progress was so far. As I say, we've been observing this, and in some cases we've got some contact with the teams, but what impressions do people have on reflections on progress so far in terms of how the 10-year plan is going? Who'd like to come in? Gwen?
Shall I follow on?
Yeah.
Shall I follow on, Ruth? kind of from my previous points around the asks. I think the mission approach and the health mission has had wide support from people across the political spectrum. And I think you'd be hard pressed to find a think tank that hasn't written a paper on missions, or very many people that are opposed to the principle. And within health, there's been real enthusiasm for that approach. So it feels like it's the right diagnosis, and at the top level, it's the right set of solutions. But the visible progress on health from government has been largely limited to the NHS, and to some extent it's been kind of focused around elective activity. And government has introduced initiatives that will have an impact on wider health, like announcements around breakfast clubs or a focus on child poverty. But there's not a sense that that's being coordinated with improved health as a specific aim. And there are also some delicate trade-offs that impact health that government's got to address. So, for example, in relation to the welfare to work agenda, where there are some delicate lines to tread about the intended impact and the potential harm that could be caused. And with health, it's always the risk that the NHS becomes all-consuming. It's a tangible entity, the public understand, and when things don't go well, there are personal stories that are really visible and resonate. And it's understandable why politicians want to jump in and fix the NHS in response to these. And some of the stories that accompany the wider determinants of health don't seem to get the same traction. But through the NHS 10-year plan process, government sets an ambition for the NHS. It's set this really bold ambition, and what's needed is similar ambition around the wider determinants of health and the things that help to keep people healthy, and will help to change the way in which people need to access the services of the NHS, and how early in their life they might need to access those services. And alongside any policies that government implements, it also needs to look at how it operates and to make sure that it's making the most of those joint working opportunities and the levers that it's got to drive change. Penny mentioned the spending review earlier. That's going to be a really key moment to see what extent a mission-based approach has been happening beneath the surface, and if significant spending has been allocated to cross-government work. And I really hope that that is what's been happening behind the scenes, and there's going to be a moment that generates the same excitement that was there when the missions approach was set out. But from a wider determinants of health position at the moment, I think there are lots of questions about the activity and not a lot to see about what's happening.
Thanks, Gwen. Really helpful. Phoebe, did you have any thoughts about what it's going, and also maybe a reflection on one of the questions about bringing back some quote unquote relics from the new Labour era that somebody has asked, which is a fair point.
Happy to try and pick up some of those. I mean, I think it's quite a mixed bag so far. There are some positives. Very quickly, that resolving that kind of industrial action was important. For example, as I said earlier, the big story early on was on kind of emphasising the depth of the problems. And fair enough, they came into power with an NHS in crisis, but that really has to shift now into what they're going to do about it. The other big story that I think nobody really expected was that this focus on reform, doing the heavy lifting, has really focused on structures today, hasn't it? NHSE being scrapped and merged back into the department with big cuts alongside that, and now a really complex task of working out who's going to do what. And again, similarly, big cuts to ICBs, changes to their functions, big questions about what the future holds for them. And some will likely need to merge to cope with those cuts. And I think taken together, that spells big disruption, distraction. A lot of time and energy will be spent working through this complex kind of roles and responsibilities. Some of it will require legislation. We know that always runs the risk of kind of morphing into something bigger. And really, I think it means a more fractured environment for when the plan does happen and lands. And that will shape what happens over the next few years, because the timeline is, over the next couple of years, isn't it, for some of those things to be kind of worked through. I guess linking to that question in the chat, a standing back point is that 10 months in, it's not really clear yet what the government's overarching approach to driving improvement in the NHS is. These recent changes have been a bit of an erosion of kind of that system working and collaboration that was embedded in the most recent round of health reforms. what will it be replaced by? I think big focus on structural change, some things that feel quite like new public management, league tables, that kind of thing. But I don't think it's clear yet what those guiding ideas are for how this government's going to use public policy to improve the service. Definitely a bit of a feeling of back to the future, but I guess we'll have to wait and see where the kind of 10-year plan and policy lands and some of those things.
Thanks, Phoebe. Penny, did you have some thoughts about how it's going quickly?
I'll build on that very briefly. Yeah, I mean, I guess just that, I mean, I've been focusing on like implementation. So what's emerging from that? It feels like the process so far has generated some warm principles, but actually what I'm hearing is it's still away from having a really credible, coherent approach to implementation. And that's kind of evident in what we've seen from the government so far, as Phoebe's flagged. And I guess I've noticed a shift in how national stakeholders are talking. So you know, there was quite a lot of talk about how the plan will need to cover the how as well as the what. And increasingly people seem to be talking about, you know, the plan will be high level with implementation details to follow. You know, that clearly raises a risk of losing some of the momentum that's been built up through the change to the NHS and the publication of the plan. You know, I hope that it's because they're really challenging themselves to come out with a sufficiently coherent and radical like model of implementation. You know, it feels perhaps there may be a risk of scrabbling around, drawing on some methods that, you know, may have worked in the past. Yeah, I mean, I guess referring to any individuals or leadership as relics may feel a little bit unfair. You know, I guess, you know, there is a broader point about the role of diverse leadership and like diversity of perspectives feeding into this work. Obviously, the kind of change the NHS process needs to bring in a very large number of voices. I'd really like to make sure that we are paying attention to like actually how the leadership and the approach to implementation really works for people from all backgrounds, so that everybody is behind that next move to implementation. When it comes to improvement, you know, I guess I was young and enthusiastic in 2000. Now I'm, you know, slightly older and just as enthusiastic. I feel like there were a lot of good things about those, the last NHS reform approach to improvement. Actually, in some ways, we could do with bringing back some of the methods that took us a certain way previously and have kind of a bit lost by the wayside. But actually, those methods are better geared to like optimizing large providers, and we're going to need to layer in methods that are more appropriate to complex large system change. Those are out there, but we can't just rely on the improvement methods that were relevant to the way we saw the world in 2000.
Thanks, Penny. And Tim, finally, do you any quick update? And I realise there are some questions that we directed to you. I think one of you've picked up already, but whether you wanted to respond to that.
I mean, just in terms of progress, you know, following what Penny was saying, I've been viewing what might be new about this plan not as being the ideas in it, but that it would actually be delivered in practice. Many of the barriers, as the government's own analysis has shown, have been that, you know, the analysis of service reform and the direction of travel and the intention has been right, but there's been a failure to deliver it in practice. If that's the case, then actually it's the change model that would need to be new about this plan. And it will be a concern if that's just devolved to a document afterwards. So it's important that there's thinking around that. On the positive side, I think one of the really good things about the process so far has been the degree of public and staff engagement in it. The government has clearly gone out of its way, including last Christmas launching that big Change NHS exercise. I suppose a message from us there would be that actually that engagement, well, it's not just for last Christmas, it needs to be continuous. And for example, the work we do on tech and AI, what we see is that the public staff, they're up for greater use of tech and AI in healthcare, but they do have some concerns around data security, around ensuring the human dimension of care isn't squeezed out in terms of safety. So the government's really going to need to keep engaging with the public and staff to understand and address concerns.
Thanks, Tim, really helpful. Well, questions are coming in thick and fast. There was one which I can't find, but it's just a very basic question about, you know, how is this going to, you know, improve things for the users of services and others. And I guess it made me reflect. We've also got a question about whether there's examples from other health systems, other countries about setting long-term strategies. And I guess it's made me reflect on the fact that one of the challenges documents like these have is they've got to do multiple things at once. They're, in a sense, they are very political documents. They've got to sort of say, this is what we as a government are going to do, but also they've got to inspire staff, they've got to put enough structure in and so forth. So I guess any reflections really on, you know, from your from where you're standing, you know, what would a good plan look like in terms of, you know, for Penny and Tim in particular, like how would you know that it's put enough thought into change at the same time as, you know, that risks then language sort of alienating people who just, you know, from our public opinion work, know that they actually want some tangible change. They want, you know, if there was a target about see your GP, I guess that might be popular.
So if I just
Tim,
jump in,
thoughts there?
I think that the change that the public want are changes in services. Some of that might require policy change. Some of it might require policy stability and supporting the system to make changes at the service level. So what I particularly look for is a recognition in the plan that some of the change is about new policy and policy announcements, but some of it is about providing a benign and stable environment that will support teams on the ground to get on and make the exciting changes that are needed in service delivery and that the public want.
Could I build on that and perhaps pick up? I mean, there's some fantastic questions coming through in the chat, so I was going to try and link responses to a few of those. So yeah, I mean, the plan has to get into the detail and start to be felt in the difference in like the practical experience of staff and patients. Clearly, you know, for me, that is one of the reasons why quality improvement will have an essential role, because that really gets into the detailed changes which allow those specific improvements within clinical teams. But there was a question in the chat about the role of QI within the broader approach to change that we're talking about here, and a separate question about actually what are the examples of organisations that have enabled this kind of transformation. I think what the Health Foundation and Q's learning suggests is that quality improvement, that kind of continuous iterative improvement method, is going to be absolutely essential for actually the reality of delivering this on the ground. But that is only likely to be successful if we embed it within a wider organisational environment which supports that kind of delivery and resourcing and implementation of that work as the mainstream business of organisations. So if you look at organisations like East London Foundation Trust, some of the organisations that went through the VMI programme, if you look internationally at organisations that have really achieved sustained high quality shifts in performance, they have used quality improvement methods as part of a wider management system. When it comes to the 10-year plan, I think what we really need to do is think about that across whole systems. So we need to get much better at joining up the kind of big vision around how services need to shift to the iterative quality improvement, and join that up with the use of innovation. So at the moment, we've got lots and lots of different activities at those different levels, but they're not effectively integrated. And for me, that's the big opportunity with the 10-year plan. But it's not easy. Thanks.
Thanks so much. Interesting question has just popped up about, you know, from someone saying this Labour government proposal, which may begin to see implementation over the next 2 years or so, which is, you know, probably fair, just in time for the next election. It is really a question about timing, that, you know, if a different government gets elected, will it continue with the plan? And it would be good to have, you know, reflections maybe from Phoebe about, you know, what continuity is possible. And maybe Gwen, if you've got any thoughts on this too. It's a 10-year plan, but we've only got a guarantee of this government being in for what, half of it, if we're lucky.
Yeah, and I think that's probably one of the key trade-offs, isn't it, that's facing the sort of right of the plan, needing to make some progress on these shorter term priorities, particularly priorities that are important to the public, and looks like access to general practice is probably going to be one of the litmus tests of, you know, Labour's record on the NHS, to see if they can buy a second term and the second half of the plan. But actually doing that, it's really important that we don't lose sight of those longer run goals and that making those longer term reform and changes. So balancing those two, is, we know from looking back in the past, is incredibly difficult, and often those short-term political priorities dominate, and we hope that doesn't happen again, and that this plan sort of cements some of those longer-term changes that are needed to make progress. But yeah, it's a great question. Gwen, I don't know if you wanted to come in on that one as well.
Yes,
Yeah.
and I think there's someone who's asked a question about how the Conservative government tried an approach and it failed as well, which you might have some reflections on. I mean, this is a sort of perennial issue here. Things just swing from one to the other, and I suppose a source of much frustration people in the sector.
Yeah, and yeah, that point about how do you make it work is a really important one. And I think for me there are two main components. The first is around leadership and really meaning it. I think the example that's been described in the chat of an initiative being announced but people not really committing to it, I think that shows that there wasn't the leadership there, and it clearly wasn't a priority. There weren't consequences or expectations about how ministers should really be engaging in the agenda. And I did see, when I was a civil servant and working under both Conservative and Labour governments, and actually around initiatives like obesity, about the difference that was made when the Prime Minister was genuinely engaged in the issue, and how much that pushed progress forward and opened up conversations that were closed. So I think there is something about the engagement of ministers across government in this agenda. And for some of I think sometimes, because the NHS is seen to get all of the money, it doesn't always make engaging with health on the Department of Health something that ministers feel comfortable doing, because they're frustrated that they're having to contribute to a health agenda when they feel that the NHS has got the lion's share of money from across government. But as I've explained, the health agenda is obviously a lot more complicated. But I think that leadership from ministers, particularly Prime Minister within the Cabinet Office, Secretary of State for Health, but also outside of health, really important. And then that accompanied with accountability. So that means setting out the clear plan, having targets so that Parliament and the public can measure progress, and government can be held to account if it isn't delivering at the moment. And I think for the NHS plan, I think I'd feel for the NHS side of things fairly confident that will be included in there and will be content, and that accountability process can start. But for the wider determinants of health, I would hope that there is going to be an indication that that's going to be included in there, but there's not a firm commitment that will be in there. And I think that's a huge gap if we don't know what the government has committed to, and therefore people can't hold them to account. And the final thing I'd say about this, and kind of linked to the longevity of it, is there's something about understanding the public and kind of public momentum and what the public wants. We've been indirectly involved in some research from IPPR recently, and this shows that public health policies are popular across different voting groups, so not just those who vote Labour. It shows that the public are increasingly taking a holistic view of health, seeing it as being intimately bound up with their work, social and family lives. And they're also moving away from seeing health as something that they are solely responsible for, and seeing the role that government and businesses play in supporting people to stay healthy. And I think the local election results show that people are really keen for urgency and ambition for government. So I think there is a public appetite for activity in this space, and there's a challenge for the Labour government to seize it, and then if that momentum builds, then I would have more confidence that it would spread into the next term regardless of the political outcome. Thanks,
Gwen. I'm just spooling through the questions here. We've now got more than I can actually process with my small brain. Yes, we're wondering whether there's any lessons from other countries. We've shared a link on that one. I think, Tim, you wanted to come back with someone was asking about the change model and engaging and involving people proactively in the change.
Yeah, a question or comment really from Jessie, who says needs to focus on how we engage and involve people proactively in the change. I totally agree. And I think there's really kind of two levels for this. At the level of innovating within organisations, within healthcare organisations, it's really important that staff and patients and users are being engaged in the change, helping to design it, and ensuring that there's support for it. If you want it to be successful, actually engaging those stakeholders is going to give you maximum likelihood that what you put in place will end up flying. I think as well then there's a national level as well. And it's an area where the government can show leadership in this plan. As I was saying, I think there's a need to continue the conversation with the public about how healthcare is changing in a range of ways, not just tech, in terms of greater ambitions around self-management, greater ambitions around providing care in the home, but on technology and AI as well. Really engaging the public in that conversation about how healthcare is changing, and in particular understanding and addressing concerns in order that people are happy with the direction of travel. Ultimately, whether or not the public likes something or not is going to be a key litmus test on whether change is going to be successful in practice.
Really helpful, Tim. And I was just going to bring Phoebe in at this point to talk a bit about some of our sort of polling and deliberative work that we've done, which shows us, strong support for this sort of shift to primary community care. And yet the elephant in the room is that, this has been stated as an objective before, we'll do this, and just hasn't happened. And, how do we, in a sense, reflect what the public think they want versus the reality of a system which is pumping money into the acute sector, which people also need? So, yeah, Phoebe, any thoughts from some of the work that we did?
Yeah, so we run public polling with a representative sample of the public every 6 months. Results from the latest round, which were carried out in November, so this government, but pre-winter. People were less pessimistic, but relatively few were optimistic. The 3 shifts, people widely supported those. But for the first time in our polling, access to GP appointments rose to the top of the public's list of priorities, followed by A&E and sort of staff retention. So it really shows this potential misalignment, doesn't it, with the kind of political priority, as you said, to tackle waiting times. Doing that political pledge will be incredibly hard. It will require a lot of resources. Doing on its own would be hard, let alone trying to make progress on these knotty issues that, as you said, have been the sort of ambitions for many years and haven't really been progressed. So I think that feels like the key trade-off really that the plan has to face up to. I guess the other realities around this issue are that resources are constrained, there's an election looming, and how can the plan kind of land on providing some clarity on this and making this shift happen where others have fallen down. I hope this one can succeed where others have failed. I think someone else wanted to come in on this one, so I'll pass back.
Yes, did anyone else have any reflections on
I guess maybe
challenge
just
of actually making this shift
real,
because it really is one that's sort of rung through from the 2000s onwards. We must do this, and yet it doesn't happen for probably fairly important reasons. Yeah.
So a couple of reflections also connecting back to our last connection about kind of co-production and involving the public. I don't have a clear solution. I think it is really challenging. I think a lot of the methods that are out there, like, we need to take further with greater confidence and kind of follow it through. I think a lot of the challenges around this shift are flow challenges. So if we can think about actually considering the kind of service flow that will support people to get access to the care that they need, there are some more kind of operational ways of thinking about it that address some of the kind of access challenges that are front of mind for people when they think about like secondary care. So, if we could address some of those flow issues at the point of referral through to hospital, if we can try and make some tangible progress on some particular issues around that kind of shift from kind of the patient journey between primary and secondary care, then I think that could allow us to make some progress and build confidence. And then in parallel, there's a sort of different mode of change, which is, you know, the kind of neighbourhood health, really leaning into co-production, understanding community assets and creating a very different kind of approach to supporting care in the community, which isn't really a shift of a current service model from the hospital to primary care. It's a fundamentally different way of operating, which allows us to get upstream and address some of the ways in which we deliver healthcare, so that we're actually meeting people's needs rather than generating what's called kind of failure demand. So an awful lot of the work that we're having to manage within the health service is a result of us not actually meeting people's needs as they occur. So I don't think it's easy, but I think we might need to recognise you may need a mix of different strategies, and some things that we can make quicker progress on while we address some of the deeper, more systemic work that I think requires a much deeper and more profound level of co-production with the voluntary sector, with communities.
Yes, and the voluntary sector's come up in a few of the questions. I was going to ask you to just reflect briefly, maybe Phoebe and Tim, if you had thoughts on this too, about the capabilities for making change. You know, you've talked about in the past, you know, I guess there may have been a sort of skewing of QI, quality improvement, capabilities and skills more to the acute sector. And actually, we're talking about often much smaller organisations, maybe individual GP practices, even scaled up in PCNs. There has been effort over the years to try and, you know, build up the capabilities, but the reality is that they aren't equal, and it will be much more of a challenge, I guess, to embed these sorts of approaches in different sorts of organisations, and including the voluntary sector, who are, you know, normally very under-resourced in this capacity too.
Yeah, so I mean, like, again, when I worked in a modernisation agency, an organisation of 800 people got like really pretty good training around change and improvement methods, and meanwhile we're starting to train large numbers and resource people in you know NHS organisations to learn these skills and apply them in practice. So, you know, at that point, quite a considerable investment in change and improvement methods. Again, overly weighted towards the acute sector. Mental health has kind of caught up quite considerably, but in terms of equivalent investment in community and primary care and the voluntary sector, they haven't been able to have the same kind of level of priority. So I think that does need to be addressed. We need to make sure that, like, operational managers and leaders are able to play their part. Often we've had a relatively superficial idea of what a leader needs to do to sponsor this change. I think we're now understanding it needs to be much more profound, so they need to have a deeper understanding. And if operational managers don't understand flow, capacity and demand, process change, you know, that is just a massive gap to like how we actually deliver change. So I think we need to be dialing up those core improvement methods in order to make the plan deliverable. And we need to recognise that we may need to put some particular emphasis on sectors that have had less investment. But I would just like to give the other side of the story, which is that I think there are a different set of methods where, you know, if you think about like asset-based approaches, like there's a set of methods and approaches which are much more focused on working with communities, on understanding and operating in a complex environment, where, you know, mental health is well ahead of the acute sector, and where there's like deep expertise and understanding, like in the voluntary sector and in patient and community groups. It hasn't always had the profile, and it's quite difficult to scale, which means it doesn't quite have the same validity, often hasn't had the same like evidence building behind it. But in terms of when we think about what's needed to implement the plan, it's got to be a mix of those kind of process and system improvement methods together with actually skills that we will find we're much more likely to find in the voluntary and community sector than in acute providers.
Thank you. Did you want to come in on that, Tim, or should we?
I mean, I agree with Penny. I think with primary care, it's particularly hard. Of course, there's hope that primary care networks can be one kind of platform for trying to support those capability gaps. It was more, though, just to comment on the premise of what we're talking about, which is that some of the key barriers to putting these new service models in place aren't professional resistance or culture or the intransigence of healthcare providers, but capability and opportunity gaps to make these changes happen. From a lot of the reports I've seen over the recent months, the government's very focused on incentive mechanisms, for example, targets, performance management. I think really the premise of what we're saying is, of course, all of that's got a role, but that stuff won't address the capability barriers that providers are facing. So we're also going to need to see some thinking about how that will be done.
If I could just build very briefly on that, I think it's really helpful to think about it in two ways. So every organisation in the health sector is going to need to have the capability to implement the changes that are asked of it within a system context. And then we also need to have the capability to make the sector as a whole work more effectively. So address the capability to scale, to learn systematically between places. So it's got to be a combination of both of those two. One thing that I guess I would be encouraged by is if we see the role that the Royal Colleges play, if we see the role that, say, NHS providers and NHS Confed really stepping up and focusing on improvement and learning as part of their mainstream business, actually we're seeing an increasing scaffolding, a set of resources that we can build on when we think about the kind of capability gap that we need to fill.
Thank you. Phoebe, I think you've spotted a question that's had quite a lot of votes about someone saying, why do we need another 10-year plan? We had one long-term plan. It remains largely fit for purpose. Couldn't it have been tweaked where necessary and at far less cost? What are your thoughts on that?
Yeah, I mean, it's a good question. You're right. The long-term plan was supposed to be a 10-year plan, wasn't it? So we're technically still in that period of implementation. I guess a few reflections on that. One is I think a lot of what was in that plan was largely blown off course by COVID, and it probably needed, as you say, a kind of reset, even if it was to remain the overarching strategy. But two other reflections, I think one reflection on that plan was that it didn't go far enough in setting out the how of change. I don't think it was going to tackle some of these long-term trends about resources and staff going into hospitals over community and primary care settings. So I think that's hopefully, if I put my optimist hat on, one area where this plan can go further and do more. And the other is that when you look at the impact of past plans, that it's very mixed. Often they are linked to spending and setting out how spending is, what it's going to achieve and what it's going to do. So I think the kind of combination of a long-term spending review and a long-term plan is not unusual. And hopefully the combination can actually give the sector some certainty and go into these years of planning with a bit more clarity over what the vision is, what the spending envelope is. So yeah, I guess that's my more optimistic comment to finish on.
And could I just
Thank
offer
you.
something in addition, which is that I think it's really important when a new government comes in that it can provide some clarity and certainty about the direction it wants to see. So in some ways you could say, well, it's not necessary, but I think actually from an expressive point of view, it is important for a new government to set out the direction it wants to see. But then just going back to many of the comments we've made so far, by a new plan, doesn't have to have changes of direction or new policies necessarily. It would be perfectly valuable in this plan for the government to endorse the direction of travel that certain things have been going in over the last few years, which would give providers and teams on the ground the certainty and stability and the long-term planning perspective they need to put successful change in place.
Thanks, Tim. There was a question that got quite a few votes that, Gwen, I'd like you to just tackle quickly, which is from April about the removing of indicators on inequalities in prevention in terms of short-term priorities. I mean, we've also talked about the importance of not having too many priorities. So stripping some out, okay, there may be a logic for it, but also this might have consequences. What are your thoughts?
Yeah, and thanks for the question, April. It's a good one, and I think it's complicated, as often these things are. And when setting ambition and deciding on the and targets, there are trade-offs to be made, because there is no one perfect target or two perfect targets that would then drive particular action. And I mentioned earlier about the challenges about this being a long-term agenda. If you take something like healthy life expectancy, for example, or life expectancy, year on year, they don't tend to change very often, and you need a period of years to be able to track any progress that is made, because even with significant investment, it's not going to change really quickly. It's going to take time. So I think it's really important that there are within the plan and within strategies, there are targets that are ambitious and that are there for the long term. But that does also need to be balanced with perhaps some interim measures, which are the best that you can do to get there, and that might be the trade-off that NHS England have been considering then. But it's one that government is going to need to be addressing as it considers how it's going to take forward these kind of the wider health agenda across government, about which areas does it set a target for, and encourage the focus that inevitably that will bring.
Thanks, Gwen. I'd like to just squeeze in one more question. We are now down to 5 minutes. But one that's had quite a lot of coverage, this question, which is about the short-term decision of radical 50% cuts to NHS England and ICBs in advance of the 10-year plan. Surely it should have been the other way around. How damaging, anyone who wants to contribute to this, but how damaging are these cuts potentially to the capability and capacity of the NHS to do some of the things that the plan might ask? I don't know who'd like to go first on this.
Yeah, I'm happy to come in. Yeah, I mean, the cuts are huge, aren't they? 50% by the end of, I think it's at some point in this year, with plans based on that blueprint due by the end of this month. So yeah, I think it's a really good question, and the kind of premise of that blueprint is that ICBs move to being strategic commissioners. I'm not sure how that marries with huge cuts to management budgets, verges covering bigger populations. And we know strategic commissioning often hasn't happened in the past because of these asymmetries in power and skills and some of those, relational and management capabilities. So I'm not clear on how these things align, or how this kind of addresses some of those previous hurdles. Yeah, I'm not sure if anyone else wants to come in. I know we're butting up against the end of the session.
Yeah, we're butting up. Anyone else add to this? Gwen had a thought.
Yeah, so I suppose my main reflection on this is just how time consuming any reorganisation is on the system, and the importance of recognising that and allowing the space that is going to be needed for that time to go through. And kind of I say that from the perspective of having been involved in the Department of Health when NHS England was created, and all of the changes that happened around there, and just the amount of leadership capacity that it takes up on all sides. And when people are thinking about their jobs and rightly thinking about their futures, that it can just impact the capacity within systems. So I think that that's got huge potential to have impact over the next year or so, quite apart from any of the financial cuts that the finances that are removed from the system.
Great, thanks, Gwen. We're nearly out of time. I was just going to ask each one of you just really briefly about what you think one thing needs to happen next, and then we'll close. So Tim, one thing to happen next.
Well, just at risk of repeating myself, it would be really to see that recognition that the value this plan needs to add needs to be about the change model, and how these very important service shifts the government's identified are going to happen this time where they haven't in the past. So I'd really like to see thinking on that in the 10-year plan, and not just delegated to some implementation document that follows in the weeks afterwards.
Yeah,
Perfect, thank you. Penny.
My point builds on that. The architects of the plan need to make space for implementation. They need to be giving a really clear invitation and support for all of those that have got a role to play to be able to contribute. So, yes, provide direction from the top based on what we've heard from the staff and the public, but then take a really inclusive and thoughtful approach to actually co-producing the delivery of the plan in practice.
Great, Phoebe.
Yeah, I mean, I think these plans are always the starting point, aren't they, rather than the final word. But I think it does just need to set that direction of travel, clear priorities, and provide some balance between short-term political priorities and longer-term change. I hope we just see it soon, actually, and there's some certainty for leaders and they can make the most of the planning window.
Perfect. And Gwen?
Yeah, so for government to announce alongside the plan a programme of work to identify cross-government action that's going to drive the progress on the building blocks of health, and for that process to get input into both the policies that are needed, but also the wider levers that should be deployed, so things like targets and accountability mechanisms.
Terrific. Thank you. We've run out of time. Bang on 11:30, slightly over. I just want to thank our speakers, Gwen Nightingale, Penny Pereira, Phoebe Dunn and Tim Horton, and above all, you for listening and sending questions. And I'm sorry we haven't answered everything, but it's been a really stimulating debate. So many, many thanks for joining us. And the website, well, up on the website will be the recording in 24 hours. Thank you. Bye-bye.